So thank you to our speakers for this first session. So now we have some time for a question and answer session. If we could limit it to maybe one question per speaker, since we're running just a few minutes behind. Is there any questions in the audience?
Well,
Oh,
I have a question to Dr. Host. Quick question in regard to the vagus nerve study. Do the patients who have maybe a cardiovascular surgery, either a heart transplant or cardiac cabbage, are they still a candidate for because the vagus nerve could be damaged or affected during surgery? Are they still candidates for the stimulator?
so for the people online who maybe didn't hear, so we're asking if patients who have already had, oh, is it there?
okay, thank you.
Yeah.
Okay, let me just try deal with the technology. Thank you very much. That's a wonderful question. I don't think that during the studies this very much affected patient group was evaluated. In general, overall, when during the preliminary phase and safety evaluations, initially with VNS stimulation, the cardiac effects were always monitored. And thankfully, the finding was that really the cardiac effects in terms of slowing the heart rate, etc., is very minimal. And it was essentially clinically not relevant.
Thank you.
It looks like we have a couple questions coming in from online. So I guess for Dr. Misra, there's a question here. How soon after TNK can a patient start mobilizing with a therapist?
Sorry.
So I don't think thrombolytics should come in the way of early mobilization. Depends on the functional status of the patient. And sometimes, practicality, if the patient is in the ICU, they're already on a cardiac drip, then obviously you don't want to mobilize them until the blood pressure is stabilized, so all those things. In general, any patient who's treated with thrombolytics or even thrombectomy, the sooner you can start therapy, the better it is. And that's what I would say.
Okay, so
question for Dr. Kent. Dr. Kent, you really fascinated me with the discussion of the post-thrombolytic or thrombectomy, reperfusion injury. The CHOICE trial looked at this a little bit, giving thrombolysis after thrombectomy. That was the Spain trial. But from what you're proposing, it may actually be better, instead of giving thrombolysis, to give a GLP-1A in a patient after thrombectomy. Do you think that that's a valid topic for a study, or what do you think?
Yeah, so the GLP-1A receptor agonists, Ozempic, Trulicity, Wegovy, we see ads for them. They're being considered acutely, which is, I think that's your question. And I think they'll be studied eventually acutely, and there may be some promise. But these glucose effects are so fast that reversing them, like with insulin, just hasn't yet shown benefit, and it's hard to do without causing hypoglycemia. So what we're really thinking of is for the next time, that if we pay attention to this patient at this hospitalization, that they had stress hyperglycemia, that we don't just neglect that we pay more attention to it. But yeah, I think it'd be very exciting to consider these more acutely. Does that answer your question?
I think we can go ahead and go on to the next session.